everyone. Thank you for joining us today. My name is Hannah. I'm the Office Coordinator for the National POLST Paradigm Office. Today we are presenting POLST in the primary care setting, part of the National POLST Paradigm Toolkit webinar series. Just a quick note that we are going to be recording this session and posting it later on our website. And you can also find links to register for the other upcoming webinars. I would now like to turn the presentation over to our presenters, Pat and Kathryn.
Thanks, Hannah. Kathryn and I thought that a first step would be for us to tell a little bit about ourselves and why we volunteered to do this toolkit. For those of you who don't know me, I'm a geriatrician. I've been a geriatrician for 41 years, which means I'm a dinosaur, and I took care of people in all care settings across the care transition. I was the care transition. I basically have spent most of my life in private practice, taking care of frail older adults and their families, and felt very comfortable helping to create this toolkit with Kathryn. Kathryn?
And I'm likewise a dinosaur, except that I'm still doing what Pat had done in the past. I live in Bozeman, Montana, which is a smallish, although growing, rural community, and I still see patients in the nursing home, in the cancer center, in the outpatient clinic, and at home. So I'm still very actively involved with primary care and run a palliative care program in Bozeman, Montana.
And Kathryn and I both want to be able to add our thanks to Pew Trust for support for this toolkit, because we see the value of the toolkit. As much as there are tools and resources, packaging it together makes a lot of sense. And this is one of a series. We want to make sure and remind you that you listen to the first in the series, which Amy did an overview of advanced care planning and where the POLST paradigm fits in. And there are more upcoming webinars, as Hannah mentioned. We really are grateful for your attendance. We really want to be able to spend the time. If we have time at the end, we'll address questions. Please put them in the chat box. If we don't have time, we will address them by email. We also plan to put all of the questions and answers into the POLST blog. So please, we encourage you to answer the questions. Hannah will also send a post test. So we wanted to start by defining primary practice, which is practice that we wanted to describe what we have been doing in our own practice. It provides health promotion, disease prevention, health maintenance, counseling, patient education, diagnosis and treatment of both acute and chronic illnesses. And frankly, as we're moving into the new world, primary palliative care, with folks like Kathryn providing specialty palliative care. And for those on the phone, no matter which of your office settings you're in, we have seen in our using the toolkit lots of variation and lots of folks that would be using it. We also recognize that they will be still seeing folks in other settings, and we would encourage them to look at the other webinars as well. Kathryn, do you want to add anything here?
No, I just think as we go through this, you'll find that this is multifaceted, and the whole idea of primary palliative care is an interesting one to me, because it does so involve having these conversations and training people around having these conversations.
I think it's the essence, Kathryn, as we talked about in preparing for this.
Yep.
So one of the things that we looked at is how would we put this together, and I had developed a toolkit as I was working with PCP practices who were either in the midst of getting patient-centered medical home certification or had just gotten it and working on additional transformation. And so we've used that as the essence of really how we frame this toolkit. Kathryn, you want to speak to that?
I'm sorry, I got distracted for a moment because I'm in my office, so I apologize. No. That's a
Okay. So we thought it was important to think about where advanced care planning and the POLST paradigm fit into primary palliative care. Thought we would define it. It's also important as you're engaging people to use the toolkit and do practice integration to be able to define it, because people are all over the place in terms of definitions. The definition underlined is from a consumer survey in terms of how they best understand it, which is interdisciplinary care that focuses on quality of life and an extra layer of support. The way I've framed it as I have been working with our practices, but also the community, is that there's three key pillars. POLST fits in as a smaller population of the general population for whom it's appropriate, but once there's a POLST or a POLST paradigm form that's been created, people need pain and symptom management, a care plan to be able to support it, and caregivers need to be educated. This is a sort of a adoption or an adaptation, I should say, of a slide you may see in the literature, but I have found it's very hard to use curative treatments because, frankly, with 41 years of experience, I've never cured myasthenia or dementia or Parkinson's disease, end-stage heart failure, but I've medically managed chronic illness and have integrated those three key pillars of palliative care in office practice before we called it palliative care. And the key here is really how to explain this in relationship to the surprise question. Would it surprise the physician if this person dies in the next year? That's the hatched line here. The solid line is would it surprise the physician if the person dies in the next 6 months? They're hospice eligible. The area under the curve shows that the three elements of palliative care, where the POLST paradigm lies in the very sick, it's a good idea to be able to take a time out and make the time to be able to have these conversations. And as Kathryn said earlier, people need to be trained. There's still the need for chronic disease management during that period of time, and people's goals may shift, and the POLST paradigm form may change over that period of time. Kathryn's an expert in palliative care and hospice, so I'm going to ask her to continue on talking about this diagram and how she's found it useful.
Yeah, and so one of the things that we were just talking about this yesterday is that there is some confusion around palliative care and hospice, and I really want to differentiate the two. I do both, but I really concentrate on palliative care, and I would say that 80% of what I do is palliative care, and it's all about conversations and understanding where a person is at the moment of their disease. It's really the surprise question comes in really at the end when we start to talk about hospice. But I rarely bring that up at the beginning, although it's, for some patients, it's the basis of our conversation. Hospice, as everybody knows, is a Medicare-funded program. There's lots of rules and regs. With palliative care, it's much more open, which is the good news and partly the bad news, because the good news is we can mold our services around what the individual patient needs and what the individual setting is. So as I mentioned, the home, the nursing home, the cancer center, inpatient, all of these areas we go into with palliative care. Hospice is much more proscribed.
Thanks, Kathryn. So the other piece that we wanted to go through were the 7 preferred practices for advanced care planning that are part of the National Quality Forum framework for preferred practices for palliative and hospice care. These have been around since 2006, and if you can think of this from a primary care practice perspective, every time you see a patient, if the next time they don't have the ability to make decisions, do you know who they trust to make decisions, and have you documented it in a state-specific form, either a durable power of attorney for healthcare or a healthcare proxy, or whatever the state-specific document is named. Importantly, do you know what matters most to them? Their values, their beliefs, the goals. The third best practice is identifying those people that are appropriate for a POLST paradigm, offering it to them, and converting their goals into medical orders based on their current health status and prognosis. Fourth is making sure that they're accessible across care settings. Next is really being able to promote healthcare, and community collaborations to educate upstream, but for the practices, how do we educate patients and families that we're seeing? From an ethics committee standpoint, it was recommended a decade ago that there ought to be some way to have the ability to arbitrate any conflict that might arise. Ethics committees may not be everywhere. Certainly they're not in each practice setting, but there should be a process to resolve conflicts when they arise. And when you're dealing with children who have the ability to consent need to be part of the process. Those 7 preferred practices were also included in the framework for the IOM report, Dying in America, and these 7 preferred practices are embedded in this toolkit as well as the framework that we're going to be talking about. Kathryn, do you want to add anything else about that?
Yeah, just a couple of things, and you'll hear this theme throughout our webinar, which is that advanced care planning promotion, a lot of times people think about it's about getting the document, and it's not about the document, it's about the conversation. We probably can't say that enough because I have to constantly educate my providers about that. And the other thing, and Pat and I have talked about this a little bit, we do not in our setting have an ethics committee, and part of that is because we have such a strong inpatient palliative care program. So a lot of the conflicts that might come to an ethics committee actually end up coming to our palliative care team. And so that while we do have some ethical conflicts, many of what we've seen in the past here have been about patients and families and helping them dialogue through these conversations.
Yep, and so I think what you're saying is there has to be a process. There has to be something in place to manage them. Terrific. Correct. The other piece that we clearly have seen in our work is that it's not enough about just teaching about the conversation or educating people about what is POLST. To be able to go into a primary care practice setting or any setting for that matter, you need to plan, you need to execute, and you need to sustain implementation of advanced care planning and the POLST Paradigm program. These are the elements that we'll be working through, and this is really the summary of what I've been doing in New York consistently in terms of leveraging this in every site of care to be able to ensure that it's not just started, that is the POLST Paradigm program, but it's sustainable long after you leave. Comments about that, Kathryn, or you want to just wait through each slide?
We can go through each slide, but I do want to say that probably the biggest and most difficult part of all this is the culture change. And having been at this for several years now and only just beginning to make an impact, it's huge. It's probably the rest of the stuff all follows.
And culture change is huge, and it really is starting from what is simply a quote-unquote DNR discussion to really a much more thoughtful discussion, talking about values, beliefs, and goals, shared decision-making, recognizing that years ago, certainly when I started, the world was paternalistic with docs making decisions. It shifted to patient autonomy, but the world is now focusing on shared decision-making that's well-informed and making sure that people understand the decisions based on what can be accomplished and can't be accomplished, and recognizing that the preferences that are chosen on a POLST Paradigm form are based on goals and a process, a communication process that Kathryn mentioned, and it's not just about a form. And then once it's done, there's a need to create the care plan based on the POLST. Kathryn, you want to say anything more about the culture change? Wonderful.
Well, only that the culture change is so key, and I just had a conversation with our hospitalists yesterday about how really what the bottom line for them is they want to know about what is their resuscitation status. So even though I've been working with them for a long time, that's still where they are, and as you know, that's not the goal here. The goal here is the conversation.
And even in what we're going to focus on today is the culture change needed in the primary care practice setting, where at least in our state, we had the first non-hospital do not resuscitate order form, and that's what was really focused on in practices, and that's why that culture shift from a form to really the thoughtful conversation is important. And we found that getting physician buy-in, particularly starting with physician leaders in the practice, is important. In turn, there needs to be staff buy-in through really the leadership of that practice. A lot of how you begin to look at what exists in the current practice and what you hope to accomplish is really based a lot on what is staff availability, is there turnover, what's the capacity to do the work, and who is accountable, which is who is the designated staff member that's going to be accountable for any of the work, and recognizing, and I think we've said it and we'll continue to say it, some of the staff discomfort with starting the conversation, knowing how to do it, and really recognizing who is going to be highly skilled and who's going to be the person who will be really leading the charge, and how does the communication of the fact that there has been a discussion, there is the existence of a POLST paradigm form, how does that get communicated in terms of office workflow, and what will be the patient follow-up for those that choose to complete a POLST paradigm form once it's been offered for the appropriate population. How is it documented in terms of the discussion and process? We'll talk later about that. If you don't document, it didn't happen. And then what happens to both the advanced directives and the POLST paradigm form? Kathryn?
I couldn't say it better, Pat. We'll be going through some of these stuff, and I can give you my own experience with it when we get to each particular slide.
Thanks, Kathryn. So I think I'm going to, these are questions that I have used since I started really leading the MOLST program in New York State as far back as 2004, and I've shared these with Kathryn as part of developing this toolkit, and it's in our toolkit. And I know, Kathryn, you've been using these questions. What have you found in your
Correct.
experience?
So I've actually found that this is a great way to start a dialogue among all sorts of staff. So I've used this with my home health staff. I just used it this morning with our nursing staff. And it really allowed them to start talking about what they were comfortable with and what they weren't comfortable with. And it brought up all sorts of questions that was extremely helpful, including understanding what the benefits of advanced directives were and and what their role was. That was the other piece that came out this morning, is what was their role in terms of what they should be doing. Were they the ones who were going to actually be having the discussion about death or about giving up hope or any of that stuff? And we had to work through that and say, well, this is what your role is, and it's not about having these conversations, but it was about having them think about it. And it was, I think, extremely helpful to the nurses to start thinking about their own ideas about mortality and conversations.
And I've used these questions in every setting, and pretty much in every educational session I will ask this as an understanding of who the audience is, to understand who has done their own personal advanced care planning, who has a healthcare proxy, who has had a discussion with their family. And oftentimes the audience are people who are going to be leading these discussions. And if they haven't done it themselves, I know there's a lot more work, because if they haven't done it for themselves, they don't recognize the value. But it's not just for those during the discussion. It's for all of the staff in a practice office. So in terms of my personal experience in practice, my staff all had it. They understood the value. They understood how important it was, so that it was located in the chart and available if we needed it, and to follow up with people. And so some of the screening questions was done by my staff because they valued it, and they understood what why they were asking people about the documents. And in my experience, in terms of what we're doing in New York as we're working with practices, we've developed both a staff readiness survey as well as an organizational readiness survey that's going to really talk about all of the other elements that we're going to cover. But these have been helpful to help focus a practice in terms of what are the elements that they need to work on, and where can we help them with those elements. the other beauty of the staff readiness survey, which is really quick, it's in both of these surveys are in the toolkit. In New York, we've put them online, and we're beginning to collect some data. It can be used serially, and so you have to be cautious. It's not something that everyone does right at the beginning. You begin to say, these are available tools, and I think we'll talk throughout this webinar that it's a lot of baby steps. It's not all at once. But we have found that this is helpful to gauge where people need to be in terms of their practice transformation in this area. Kathryn?
So we did not use the staff readiness survey just because we didn't have it when we started working on advanced care planning and what we needed to do for our organization. But we did a similar kind of thing with the stakeholders in terms of coming up with a SWOT analysis, which I'm sure everybody's aware of. It would have been extremely helpful to have had this survey, this staff readiness survey, when we started out, but we've sort of moved past that stage at this point. But I think in retrospect it would have been great if we'd had it.
And one of the reasons that I've used it and developed it for our state is that we've been using assessment of advanced care planning for our employees since 2002, and over the course of time, having a sort of population of about 5,000 to 6,000 employees, a lot of young people, I've seen that people are much more open to dialogue and understanding the process. About 60% of our employees have healthcare proxies. They've done discussions, and that's with all turnover. And again, a lot of young people, which is higher than the general population, but it also opens people up to asking other questions about other issues, and that I think has been some of the value. Mm-hmm. Obviously, professional training is necessary for everyone in the office, and we'll talk a little bit later about the kind of training that people who are doing the discussions need. This kind of general training across all office staff is consistent with the core elements of POLST education that are posted on the website, that you really need to educate everyone. And you'll see in this image, it goes beyond the PCP practice, because if the practice is doing it but the rest of the continuum isn't, then it becomes a barrier to making sure that people get what they want. Kathryn?
Yeah, absolutely. And again, in my experience, getting physicians and providers on board with this is the trickiest part, for a lot of reasons that we'll talk about as we go along.
And so when you think about training everyone, it's sort of basic, and that's what's in the core elements of POLST education, and that's what we've used in New York, but it's also what we're recommending in the toolkit, that everybody needs to understand advanced care planning to be able to understand the context of what is the POLST paradigm. And these are the objectives. We encourage everyone to do their own advanced care planning, complete their documents, and there's lots of ways that you can do it, given that you want to educate everyone and you likely have limited time. And also, people learn and grasp information in different ways. So what we've used is, either self-directed learning. We have booklets, we have videos. It can be done during lunch and learn. It can be done during a staff meeting. There have been lots of options that we've recommended and that people have used.
And I would say these are just some of the options. Yeah, these are just some of the options. In my experience, the self-directed stuff, I'm not sure how, without making sure you know exactly what the self-directed content is, which is certainly something that can be done, I'm not as excited about that part as actually having a conversation with my providers to really be able to have them ask me questions and participate with them.
Yeah, and what I'm looking at here and thinking about also is not just the physicians and the clinicians that will be involved in the conversation, but the front office staff, et cetera. And so a video that really says the POLST paradigm is important because of these elements. And what we've found is that really linking it with patient stories has made the most impact. What happens if there's not a POLST paradigm form? What happens when there is one? And one of the key pieces that we've tried to do is, and we'll go through this quickly because this validates and builds on what Amy did in the first webinar, is really understanding advanced care planning as a process, understanding that we don't want to wait till the end. This is where the surprise question, would it surprise you if this person dies in the next year, 6 months, early identification here. There may be some healthy and independent, typically folks of advanced age, who may have strong feelings about the kinds of treatments they wish to receive and avoid. And they have their rights under Patient Self-Determination Act to basically say, I wish to accept or refuse treatment. It doesn't end at the end of life. That doesn't translate to every healthy 65-year-old, and that's why having the conversation and educating one-on-one or in a practice setting is very helpful. This is the majority of folks with POLST paradigm forms trying to drive it upstream. On the other hand, everyone along the rainbow, whether they're healthy, have a chronic illness, it's advancing, multiple comorbidities, ought to have a healthcare proxy or durable power of attorney for healthcare, whatever the state-specific form is, to be to basically identify who they trust to make decisions if they lose the ability to do so. Because if they're not ready for a POLST paradigm form and they suddenly lose capacity and are appropriate, it's that surrogate who's going to be making decisions on the POLST paradigm form. It's also been really clear how important it is to divide and distinguish traditional advance directives versus actionable medical orders like the POLST. And there's a whole document on the website, and it's included in the overview of the toolkit, to differentiate advance directives and medical orders. Kathryn, do you want to say anything about these two slides?
Yeah, well, this slide and the next slide actually have been key in terms of educating everybody about the difference between advance directives and POLST. It's been fascinating to me because to me this rolls off my tongue because I've been doing it for so long, but it doesn't roll off everybody's tongue. And I think that you need to really, I've been using this slide for my medical students, I've been using it for the front office, the nursing staff, the providers. It really helps people understand the difference between advance directives and POLST.
And underlined in bold is really the line that talks about time frame. When I've done the education, advanced directives are about future care. We don't have a crystal ball. POLST is about right here, right now. The slide that we showed initially was published in JNCCN, so that's over a decade old, but that's been very helpful in our state to help people to think about cohorts of individuals and the right people who are appropriate for POLST.
So, and I would just add one quick thing which went on this morning actually was the difference between a 98-year-old who one of the nurses brought up saying that they wanted to be a full code, and those of us who do this know that that's not going to be terribly successful, and then another nurse brought up the 50-year-old who wants to fill out a POLST, and I had to sort of go through them and show them this slide about why that wasn't appropriate for a 50-year-old to have a POLST, but it would have been very appropriate for this 98-year-old to have a POLST.
And I would suggest this is a very simple article that was authored by myself, Judy Black, and Marion Kemp in the Cleveland Clinic Journal of Medicine, and it has case illustrations to illustrate exactly what Kathryn's saying, but also to say for that very sick person who had advanced directives what the value of the POLST paradigm was. We also use that in illustrating it with some clinical pathways. These were also published in the JNCCN article, which was about integrating the POLST into palliative care guidelines in oncology practices. And if you see here, this is a clinical pathway, and there is an active link to point on our website where all of these elements really pop up other ways that you can have this discussion. This is really about advanced care planning in general, and it really is based on behavioral readiness theory and how to move people along the pathway when they're not ready to do an advanced directive. The next slide are people who have a life expectancy greater or less than a year versus greater than a year, and the only difference is completing a POLST form. So basically, if people have not done any of this work, there's a lot more work to catch up on, and that's where, even for people who are thinking they're okay with their advanced directives and don't know about POLST, they're not ready for shared decision making. The pathways also integrate palliative care and hospice discussions as part of the options. Kathryn, I know you like these clinical pathways, or you've started to use them. What do you think?
So we're redesigning them a little bit to fit our workflow, which has taken a little bit more effort than I thought it would, because one of the things that we run into is that the nurses are giving out information, for example, giving out information about advanced care planning and maybe giving out a document, and there's no way to know that they're actually done or what the follow-up is. So one of the things that we're working on in terms of these clinical pathways, which are great, is figuring out our own patient flow within our own clinic, that how do we make sure we've given them the information, we've looked at the barriers, what's our follow-up, and that's been a challenge.
So the clinical pathways are a little different than the workflow, because you're absolutely right. You need to look at that workflow to make sure that the work gets absolutely done. So the other piece, another tool that we have in the toolkit, is really some basic screening questions. These relate to advanced care planning. Does my patient have a health care proxy? Do I have a copy? Have I talked about values, beliefs, goals for care? Person talked to their family. Is the person appropriate for POLST? You can substitute durable power of attorney or whatever the state-specific form is for those questions. And then these are some screening questions that basically take that surprise question and blow it out. I am impressed when I'm talking to clinicians in practices that, frankly, people are not familiar with the surprise question. And having a clinical approach and thinking through that helps them to identify patients in a very clinically oriented way, because although we think it makes sense and we're familiar with the literature, it's not that case in my experience when you get down into the trenches.
Right.
Anything to add, Kathryn?
Absolutely. No, and again, the surprise question has been the question that I've used in every single setting, and I'm not sure that many providers know about it, and part of my training that's going to happen in a month from now for all of our providers, so that we're all on board with it. And if there are questions about the surprise question, please put them in. It just has been an incredibly useful tool, not only for providers, but for patients and family to understand what's going on with their clinical course.
So the next section is really going to focus on how to make sure that we're educating those folks that are doing the POLST discussion. This is one of my favorite slides from the New Yorker, and I've used it forever. There's no easy way I can tell you this, so I'm sending you to someone who can. And there are lots of elements in terms of making sure that the POLST discussion is thoughtful. Physicians and clinicians need to be trained within scope of practice. I'm always clear, because there may be case managers in an office setting who are social workers, that it cannot fall on their shoulders alone to do a POLST discussion. And I will ask physicians when I'm in the office, would you ask your case manager, who's a social worker, to order antibiotics for pneumonia? Would you ask her to, basically make the decisions about any of the treatment that you're advising? Then you wouldn't ask her to make life and death decisions. On the other hand, she has a skillful role in terms of conflict resolution and communication skills, the ability to understand family dynamics and help with families who have some level of dysfunction. The communication skills are important. Having a standardized process has been really helpful in our experience in New York. Understanding what the form elements are, the FAQs, and there are FAQs that are included in the overview of the toolkit that is the first section, but also then understanding evidence-based guidelines. And Kathryn already talked about, for those appropriate for the POLST, or alluded to it, that this is a population for whom CPR doesn't work, because it's the underlying disease that causes the death. Understanding how to do conflict resolution, and we've talked till we're blue in the face as we prepare this toolkit, the importance of proper documentation and leveraging the CPT codes. One of the first things I learned as a young physician is if you don't document, it didn't happen. So this is kind of the overview. Kathryn, you want to add anything in terms of this list?
Yeah, I would say the communication skills are probably way up there, and one of the problems that I've encountered is I've spent a lot of time improving my communication skills because that's what you do as a palliative medicine doc. And trying to distill that down to give to the primary care providers has been somewhat of a challenge. And I think the other thing is the scope of practice. Who is having these discussions is really key. In the nursing home, sometimes I find, there are nurses who are totally untrained having some conversations, which is a little disturbing to me. And then we will talk about the documentation. That has been a major stumbling block for our organization to get that in place before I can actually bring it out to providers, because the providers have said to me, how do I document, where do I document, what do I say? And if I don't know how to do it, and it's taken a year for me to get that system set up within our electronic medical record, they're not going to listen to anything I'm saying. So
one slide out of a lot of slides and a whole sort of lecture that I do on effective communication skills is really to get people focused on talking less and actively listening more, and to really kind of be in the present moment and to allow yourself to listen to what people are trying to convey, and then to reflect on what they're saying and to really basically communicate the fact that you are listening and that you're understanding what they're saying by using the same language. For instance, if someone says, dignity is my priority, being able to say, we'll do everything we can to ensure your dignity. But really, it's about listening more, active listening, and making sure you're understanding what people are saying in terms of what their values, beliefs, and goals are, but then making sure that people understand the choices through shared decision-making, which we'll talk about next. And the ability to resolve conflicts, and it happens at every level because there are lots of members of any one family or family by choice, and if people have differing of opinion, it's always an important way to bring it back to the person for whom the decisions are being made, either themselves or being made by a surrogate. There are lots of ways to teach communication skills. Kathryn, you want to add some more in terms of communication skills?
Well, I was just thinking back to what you had said, Pat, and when you talked about how somebody wants to have dignity, and I would add to that, well, I would go back to them, what does dignity mean to you? Because I think it means something different for each person, and that whole thing of rephrasing and reflecting back and asking what are they really meaning by that is so key in all of this.
Yep. So this is the 8-step POLST protocol. I put together the 8-step MOLST protocol back when we started our MOLST program and started rolling it out in 2004, and it was published in 2005. And the reason that this is important, and it's part of what is part of basic practice in terms of having any type of thoughtful end-of-life discussion, but I use this and really get into each element by saying it's only step 7 that you're going to sign the POLST, and you're going to make sure you follow any of the ethical framework that's coded into your public health law, and make sure you document the conversation. But just being able to start here and then working through each of the elements in the office setting to make sure that people know is important, because that will become part of the workflow that we'll talk about later in terms of how you're going to prepare, particularly if you have a schedule and you come upon someone who wasn't you didn't think they were going to come into the office and are appropriate for a POLST conversation, that you need to start today. And how do you manage that office schedule if they really need to have that discussion today? So it's really about process, and then it's going back to what Kathryn said earlier, how do you manage the workflow? Anything to add about this, Kathryn?
Yeah, I would just say that you could also redo this as an 8-step advanced care planning protocol because it's the same stuff. I go through the same thing with certainly with my seriously ill people. You can do it for the people who are not seriously ill, but it still is really the same kind of stuff that you're going to do in each discussion.
And it's also for people who are not yet ready. They may be eligible for the POLST, but they're not yet ready to do it. And we have basically, in our email system, have basically documented all of this so it's in one place, but say they're not ready. So the documentation of the conversation and the series of conversations are in one place, and then when they're ready, the form can be completed. What I've taught is what I've used in my own practice for shared decision. Did you want to say something, Kathryn? I'm sorry.
Oh, just I was going to just quickly add that lots of times if I go through this kind of stepwise protocol, the POLST itself takes me about 3 minutes. You know, I've already been there, done that. We don't even have to spend a lot of time talking about the actual document because we've already had the conversation.
And I'm glad you said that, Kathryn, because I think it is the essence of what is primary palliative care in an office setting. So as we're teaching people in the primary care practice setting and moving it upstream, this is really the essence of it. Completion of the documents, be it advanced directives, be it medical orders, meeting people where they are in their place when they're ready to do it is what this is about. Very quickly, these are the 4 questions for shared decision-making for each item on the POLST form. What I always point out to folks, and I think everyone knows this, is if there's hope for recovery, what's life going to be like afterwards? Because if we don't talk about that element, people can't really put in their values and goals. So if Kathryn says to me in a conversation, if I'm recover, I can continue to lead New York's MOLST program, I may make one decision. If she tells me in the midst of a conversation that life afterwards will be, I'll be in a nursing home on a ventilator with a PEG tube, and my goal is to see my new grandson who's going to be born in August, you can bet I'm going to make different decisions based on my goals and what the outcome's going to be. But this kind of decision-making, shared decision-making, needs to accompany each one of the items on the POLST form.
And I think Kathryn, where we fall down, I think where we fall down the most on this is the hope of recovery. And part of that, I think, is our own hope for recovery, but I think, and also what is the data out there about who's really going to survive? And I know you're going to go into a couple of CPR slides, but we don't, as providers, really talk about that, I think, as much as we should. What is this going to look like after we've done something?
I think it's a major downfall for all of our colleagues in terms of missing that element. That's why there's a call out for that. And as Kathryn said earlier in the presentation, for people who are POLST appropriate, there are poor outcomes with CPR, be it an unwitnessed arrest, people with metastatic cancer, multiple chronic illnesses, frailty, sepsis. Anyone who's appropriate for the POLST, it just doesn't work. It works less than 1% of the time, and if it does, basically most people don't survive, and they certainly aren't the same after that arrest. And it's not because we're not good at it, it's because of the underlying disease. And in the community, in my experience, the expectation of survival is, 80 to 90%, and that's real in terms of really asking that in community presentations. So that culture change from, let's just ask about DNR, if your heart stops, you want us to start it, to a more thoughtful discussion, which is the POLST. If you don't really walk through these, shared decision-making steps, people will say, of course I want CPR, dumb doc. It works on TV. Kathryn?
Yes, absolutely. I have nothing to add to that one.
So we just included this here for information so that you would have that information at hand. And the other place is to look at.
Sorry, Pat. I
Go ahead.
would say that one of the pieces of information that you might want to have, and I talked about it with the nurses this morning, is a fact sheet about CPR because people have so much misunderstanding about it. And there are some really standard ones, and we have one on the POLST website that you can use as an education tool.
Yeah, and we have a whole web page, and we've had it out there that includes also references that really gives where these statistics have come from and a presentation just on CPR. So getting that information out there is important. Equally, this is a tool from a toolkit that we've put together in Rochester to support the POLST program back in 2004. We review it every other year. We look at the evidence base, and this tool, of all of the tools in the toolkit, is one that I think even our surgeons have really seen as beneficial because it looks at it, the value and the benefits and burdens of feeding tubes from a diagnosis-specific perspective. There's an active link to all of the toolkits so that you can take a look at it. It's also in our POLST Paradigm toolkit. Another element that everyone needs to know is what is on the individual state's POLST Paradigm form elements and the FAQs, not only from National POLST, but if there are explicit FAQs that are really state-specific and integrate the laws of the land in that individual state. And as you know, every state can have a different name, and so we're talking about the POLST Paradigm, and you can adapt what's in this toolkit, the first and the upcoming, and integrate the elements for your state. So, Kathryn, I'm going to let you talk about documentation because I know this is your bugaboo, as is mine, but I'll let you talk about this.
Yeah, well, I'll just tell a little quick story. About 2 years ago, we moved over into EPIC, and I thought, great, God, this is terrific. We'll be able to find the advanced directive really easily. We'll be able to document our conversations, blah, blah, blah. It is, as I said, taken over a year for me to get an appropriate flow where people can document and we can find everything. Now we have in a one window a place where everything around advanced care planning lives. You can get to the documents, you can get to the patient's capacity, and I put that in quotes. You can get to who the healthcare decision maker is. You can get to any advanced care planning notes that are done. However, it still takes a tremendous amount of training within our organization to get all the providers online about it. So if you just, for example, just as a simple example, if you put in who the healthcare decision maker is, if you put it in and you don't complete the field, it will not come over into this other field to tell you who the healthcare decision maker is. It's simple to do. It's just one more thing that I have to train the providers about how to do it. Same thing with an advanced care planning note. Best practice would be if you have a discussion about advanced care planning, it's in one particular spot, and it is in our system, but for a provider to do it, they actually have to do two different notes. In addition, we've gotten a template from our mother organization that doesn't fit the paradigm that we've been putting out here for you in terms of what a discussion should look like. So I have to train our providers to get rid of that template that they have. So you're going to have to figure out within your own system what works best for you, so we can give you the key elements of what it might look like, but you will have to figure it out. And it would seem like every epic is every epic, but as we know, each epic is you've seen one epic, you've seen one epic. So this has been a major issue for me to get going before I can go to my providers.
The other piece about documentation is if it wasn't documented, it didn't happen. So from a professional liability perspective, it's much better to have these elements. These elements also align with the protocol that we talked about earlier. So there's lots of ways to approach it, and trying to make it simple and accessible in electronic health records is important, as Kathryn said. Once the POLST Paradigm form is done, it's not completed. If your patient in your practice doesn't want to go back to hospital, you need a care plan that supports the POLST program, be it hospice, be it palliative care, but you also need to have medications ordered, and caregivers need to understand. As an example that I always use is someone with severe COPD who has had multiple episodes of hospitalization, intubation, almost needed to be permanently trached and said enough is enough, doesn't want to be hospitalized, doesn't want to be intubated, and is appropriate for morphine. Giving the morphine prescription is not enough. Educating about the fact that morphine will not make grandma an addict or kill grandma is important. Otherwise, family may not get the prescription and they'll be back in the hospital and the POLST paradigm won't work. Kathryn, you want to add anything to that?
Yeah, the one other thing about documentation that I've found has been an issue in our system is actually getting providers to look at the actual documents and to review them. I've found some very interesting, shall we say, advanced directives on patients that I've either inherited or have come to me from lawyers with various things. And no offense to lawyers, you need to really look at those documents and not just say, somebody's got an advanced directive, here it is, this is their decision maker, but really sort of look through that document. I had one patient where at one point it said, I do not want to be resuscitated, I don't want to be on dialysis. And the next page said, but I do want blood transfusions and I do want to have dialysis. So it's taken me 4 different meetings with this family to get them to understand what the issues were and what the problem were. So I think part of the documentation, which I'm trying to get through to my providers, is that you've got to also review the documents and look at them and really pay attention to what they're saying.
Well said, Kathryn. The other piece that is part of shared decision-making, aside from educating all of the staff in the practice, educating to a higher level those that are going to be involved in the conversation, is also educating patients and families. And that's really the only way that true decision-making, shared decision-making can occur. And we have found in New York that using videos with real stories helps to get people to understand what the POLST Paradigm program is. Similarly, there are videos that are on the POLST.org website that you can use. So there's a lot of tools that are out there. Many of them are in the Toolkit, and in many respects, in many instances, we refer to POLST.org to our resources because there's more than enough, and we didn't want to be repetitive. The kinds of things that the IOM report has basically said in terms of advanced care planning in that chapter is really saying that individuals can and should take control of their life, and they should have the ability to make their decisions. This aligns with the POLST Paradigm program. It's also recommended that physicians initiate this discussion. It becomes easier said than done, but engaging physician champions in the office is one of that first step. And also recognizing as you're educating patients and families that people receive and use information in different ways. So we try to at least give examples of different ways to educate patients and families. And so we've just given a few here in this slide, but you have to look at the individual that's in front of you to know how they will be best educated. Kathryn?
Yeah, and it takes all sorts of different forms. I mean, we've had a group that puts on a community conference every year about end-of-life care, advanced care planning, and it's been greatly successful, but it hasn't reached the providers. But it's great to have the community educated because then they come to us and say, what are you doing, where are you going, and help us.
And because April 16th is around the corner, can't go without plugging National Healthcare Decisions Day. It's the 10-year anniversary. As part of the work to support New York's MOLST program, I put together a coalition that are really grassroots people across the state who are educating in communities. And I would recommend anyone who's on the line, who's leading a state program or engaged in their own community work, to see how you can connect with that, because that community education is really important. I'd emphasize what Kathryn said. The better the community is educated, when people come in, they'll be educated, engaged, empowered patients and families to be able to connect with the physicians and other clinicians who will be working on POLST Paradigm within scope of practice. I see we're moving along, so I just want to move forward.
I'm concerned about our time here, Pat.
Yes. I'm just going to move ahead and say we want to work on
Keep going.
system
Keep going.
So system implementation, really, there's a lot to look at. And I think it's one of the things that is really, at least in my experience with talking to practices that have so much to do, they just don't know how they can fill this in. So we have put in the toolkit sample policies and procedures, ideas about workflow and how you move from the current workflow to the future. For practices that are already using a pre-visit planning process, we've put in some tools to add advanced care planning for the general population 18 and older and those appropriate for POLST into part of that screening process. There's the staffing considerations, how will you operationalize it, and that's what Kathryn was getting to in terms of taking those clinical pathways but seeing how will you make sure that it's going to work, and some operational considerations. The most important thing is that it takes a lot of work, and if you make small changes and you can get those in place, that helps. What we've found is that people do need this toolkit, and we've seen that in our the practices that we've worked with, as well as a work plan. How will they move it forward and get all the other work done? So that's why it's important as part of culture change to identify a physician champion in that practice setting as well as a system champion, the physician who can meet with the others and the system champion who can help with some of this workflow in the office. Kathryn, anything else to add?
Well, I just have one quick thing, and Pat, I don't know if we're going to get through everything, but which is that the quality department is your friend. They have been really helpful in my organization to move things forward because they've started to recognize there are some real issues in terms of the quality of the advanced directives, the quality of the POLST, and the workflow, and so they've been helpful in making the organization pay attention.
And in a practice setting, small quality improvement projects have been the way I've approached it. We've given some ideas in terms of what quality measures may be there, but you need to take the baby steps and see how it all integrates to the individual practice, as well as if they have paper records, hybrid, or EMRs. Importantly are the dedicated physician and system champions, and making sure if that practice is part of a larger health system that it aligns with what's happening down the road. So every practice is going to be needed to be approached differently. Some will be independent, some will be part of a larger practice, and you can leverage how the health system's priorities are aligning with some of these elements, and that will help to get buy-in in a practice in a larger scale. The other thing that's important to consider is that POLST will take time, and one of the key barriers is I don't have time, I don't get paid, I don't know how to do this. And the new CPT codes really help to overcome it, and I'm impressed as I'm going out and talking to docs how many are not really using the CPT codes. But we did put in some information in the webinar, but also in the toolkit in terms of the definitions of the codes, how to leverage the codes, and really who can provide the services, which are physicians, other qualified healthcare professionals who are enrolled in the Medicare program. In terms of the POLST paradigm, that makes sense. In terms of the workflow for other elements for advanced care planning, those can be picked up by other staff members so that everyone can work as a team. We've put in definitions and these are right from the ACP section in the final rule, and there's sheets in the toolkit that you can use. As you look at this and you see how to bill, then you can also say these are the elements that are frankly needed for documentation. If you look at the clinical examples from the CPT manual, the first for 99497 is fairly simple. 66-year-old gentleman comes in with heart failure and diabetes on lots of medicine, wants to talk about advanced care planning. That's really advanced directives, the same kind of documentation as Kathryn pointed out earlier, whereas the second is someone who's just discharged from the ICU, had been intubated, the most recent of several episodes, and wants to talk. That person may be POLST eligible, so it's going to take a lot more time. And finally, we wanted to talk a little bit about digital transformation. Kathryn's already spoken about this, and what we've done in New York is really combined all of these elements in terms of documentation to create a system that's a web-based application to make sure it's done correctly. And that's where we really need to go. And from a POLST perspective, a single click on the toolbar is what we've talked about. We do know there are challenges and practices to get this done. From the provider's perspective, we've talked about the EHR, we've talked about the organizations and multiple priorities. What we've seen is as long as you can align with some of the key priorities in that practice and try to take baby steps, we've seen progress. And the good news is people are looking at it. It's a quality issue, and we have the toolkit that's available. We wanted to just talk about what are the next steps after this webinar. We encourage everyone to read the toolkit and the appendices, and as you're going into a practice and thinking of what practice should I work with, who are the early adopters, meet with the practice leaders. Know it's going to be different everywhere you go along the line, and you'll probably need more than one meeting and see where there are opportunities to align what you're bringing to the practice and what they're doing. And recognize this is a multi-year process. It's not going to happen overnight. And in our experience, you have to plan it, you have to execute it, and sustain it. And it may be small baby steps. And looking at some value through pilot projects. Kathryn, I know you have a lot of thoughts about this as well before we end.
Yeah, all I can say is take a deep breath and take your time, because it will take time, and once you get there, it'll be great, but it's going to take a lot of time. And every setting, the toolkit is, I have found in my setting, is a great tool. However, you have to adapt it to your own setting. And I would say that both Pat and I are available to talk about this offline. You have our emails, and please feel free to contact us about any of this.
And we went through it in great depth, not in great depth, but pretty quickly, but there's a lot more information there. And the only other thing I would add to what you said, Kathryn, is we recognize that this is a work in progress, and as we get more experience with this, we expect that there will be more tools added or more ways to approach it. There's more than one way to skin a cat. And I'd also say it's integrated with other tools that already exist on POLST.org. And please go to your state map or the U.S. map and look at your state POLST Paradigm program, because there may be specific tools there. We could not include every tool in the toolkit and gave examples. Anything else, Kathryn?
I don't think so. I would just encourage people to get in touch with us, and also that if you do start using the toolkits and have any advice for us or think something could be done differently, please let us know.
Thank you so much for attending, and we'll look forward to getting your questions.
Both so much, Kathryn and Pat. Any questions, please reach out, and otherwise, have a great afternoon, everyone.
Bye-bye.